Good morning. Before we get started, every 40 seconds, someone in the world dies from suicide. We're going to have a moment of silence for 40 seconds to honor those who have lost their lives to suicide and vow in those same 40 seconds that we will continue to work together to stop suicide before it happens. Thank you all for that. You are in the right place. This is the National Academy's Forum on Mental Health and Substance Use Disorder. This is Strategies and Interventions to Reduce Suicide, a virtual workshop, part 2. Today we highlight Building 988 and discuss its implications, the current lifeline services available in different settings for all people. This will be an interactive webinar. We encourage all of you to use the Q&A at the bottom of your screens and to submit questions for the speakers, and your questions will be answered, during the Q&A. Now, next slide, please. Let's thank the National Academies for hosting this timely workshop, all of you for making the time to be here, our esteemed thought leaders who planned this workshop, and this includes Matt Turney, our FEARS chair, along with myself, Mary Rory. I am the director of the Office of Behavioral Health Equity at SAMHSA, Erin Begelman, Michael Hogan, Lily Mells, Andrew Moon, and Jane Pearson. There's a special thanks that we need to give to the forum staff, Alejandra, Anicia Wilkes, Adrian Fermentos, and a massive thanks to our over-the-top, celebrated, dedicated, but only committed, but they made the time to be here with us anyway, distinguished panel. Next slide, please. To learn more about the forum and their offerings, please click on the link below. This will be a dating robust forum. Speed dating, yes, speed dating. Your call to action is to not let suicide happen, work feverishly to prevent it, and continue working with all to achieve and sustain zero suicide attempts and death. It was always here, but COVID-19 and the ongoing nonstop civil unrest has taken suicide across the lifespan over the top, and it has increased by 29% according to the Center for Disease Control. Today, we want you to focus not on your emails, but on this forum, which can be life-saving for you, others, and the people that we work with. Your job is to ask, no matter how awkward, stigmatizing, stereotyping, are you safe? Next slide, please. This slide shows the power of partnership and collaboration made possible by the following. So massive thanks to all of those partners. Next slide, please. Now, if you missed part 1 of the part 2 series, here's what you missed. Last month, the forum hosted part 1 of this series, U.S. Suicide Subgroup Trends, Opportunities in Healthcare to Reduce Suicide Risk. The key themes that emerged were cultural competency and health equity. The barriers in suicide prevention and interventions, such as the lack of access in healthcare services and healthcare provider shortages that was exacerbated during COVID-19 and the ongoing civil unrest. Sustainability needs to be built into planning, as well as quality of implementation of these programs, and An extended research focus should target traditionally under-resourced and marginalized groups such as American Indians and Alaska Natives, members of the LGBTQIA+ community, and Black youth. Other high-risk groups include our military, veterans, and homeless populations. But don't despair, because there is a free save recording available archived on this website. Next slide, please. Today, we're going to talk about Building 988, and they're the onslaught of speakers who are, by the way, over the top, world's best subject matter experts who will continue to lay out part one of this part two series. Why now? So what about suicide from a multi-social, dynamic, systemic, community, individual perspective? 988 is what? And if you need resources, we will share that too. Now, the moment that we have all been waiting for. Today's session will continue our discussion highlighting the importance of equity, access, and prevention, beginning with our outstanding keynote, Mary Ann Neihart. She is the Associate Director for Patient Care Services for the San Francisco Veterans Administration Healthcare System. All of you, thanks so much for your undivided attention, and also note that the full bios for all of the speakers can be found on the event page. Over to you, Mary Ann.
Thank you so much, Mary, and good morning to everyone who's joined us. It's an honor to be here to share a story that, you know, is way too common in this world. It's way too common in more communities than you might imagine. We hear about some very challenging situations that absolutely make national news, but I'm here to share with you there are many, many more, and I want to start by talking about next slide, please, a very sleepy little community in which I live. It's a coastal community by the name of Pacifica. It was, we thought, very calm, very community policing oriented. And I happened to be mayor during the time of this occurrence. X, just hit the button, yeah. We were actually rated one of the 100 safest cities in America. But you get some attention, next slide, when one very beautiful morning in the spring, a mother, Christina, and by the way, I'm using all their names. You can look this up. It's all been public information. But Christina called 911, and she was concerned about her son, Errol. And he had been living in the community. In fact, the boys all grew up in Pacifica, so they were well known. And his father still maintained a home in Pacifica. Errol was at his father's, but his mother became very concerned. She told the dispatcher that he was experiencing paranoia, that he's thinking people are wanting to assassinate him, he doesn't trust anyone, and she was very, very worried that he was going to hurt himself. The police went out, and shortly after that, there was a whole bunch of social media that showed up wanting to know what was going on, why is my street blocked, why can't I get to my house? Because Pedro Point is a small section of Pacifica that is sort of isolated and a very tight community. It's in that community that the police went out and spent 6 hours talking to Errol, working with Errol, trying to get him to come out of the house, to reassure him. They got his favorite police officer out there. They were doing an amazing job. But in the process, his father showed up. And his father unknowingly said, you know, there's weapons in that house. Pacifica, along with most cities of the 22 cities that are in San Mateo County, actually has an MOU with the police across the county that utilizes our 2 SWAT teams. And at the point they experience weapons in a situation like this, or know that there might be weapons, they are obligated to call the SWAT team. Now, what I want to share with you is what happened subsequent to that. I want you to know something. If you're sensitive, if you feel like you might experience a reaction to this, this is a pretty powerful video. It has a number of weapons, and you'll see the SWAT, you'll see what happened and what transpired. So if you think you might experience some triggering, I want you to feel like you can step away, blank the screen, turn your sound off, because this is what happened after 6 hours with the police. Go ahead.
Harold, you need to come out. Harold, now. Harold, you need to come out the window now. Harold. Harold. You need to come out of the house.
Paranoia.
No one's going to shoot you. You need to get out of the house, though. Get out of the house, Harold.
In the back of the head.
Cell phone video, so it has some errors.
Harold. You need to come out. Harold. Harold.
Their dog think those explosions are pretty good.
Harold, get out of the house. Harold, keep your hands off the window. Do it now. Do it. There you go. Keep your hands off the window.
I said, fuck that. All my off all those explosions.
Harold,
I'm
get out of the
out.
house.
Whatever.
Harold, get out of the house now. Harold, get by the house. Harold. Harold. Come out of the house, Harold. 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 Harold, step out of the house now. Come on, Harold, you need to step out of the house. Come out.
Fucking dick.
Harold, you need to step out of the house.
Did that to block the noise or something else.
You're certainly welcome to find this online. It's still accessible. But next slide. What they were seeing was exactly this. Errol trying to talk through the window, the SWAT team organized outside. You see that the repetitive communication that was happening from the SWAT commander, just saying the same thing over and over in this big black box. And all these guns pointed at a young man who was already experiencing paranoia. Next slide. Errol put his hands up, put his hands out. Errol was talking to the police as he had been for the past 6 hours. But 20 minutes after the SWAT team arrived, Errol was in fact dead. Next slide. The SWAT team entered the house. Next slide. They breached the door. Next slide. And as a result, we were experiencing a tremendous loss in Pacifica. There was a candlelight vigil that night. There were all the things that you would expect, but you never heard about it on the evening news. What's worse, I mean, if anything could be worse, 3 months later in Half Moon Bay, 11 miles down the road, another young woman who was 18, who had schizophrenia, her family called for help from the police because she was refusing to take the meds. She was very upset. And her brother called the county sheriff, different situation, but ended up with her death as well. 2 coastal communities inside of 3 months brought forward a lot of concern. And I want to share that with you because families reach out every day for help from the police. And the police do what they can. But this is something that resulted in a community action and a family action. Next slide. Errol's brother and his mother have taken up an advocacy that after all the help from the local police, this would happen, and that in San Francisco proper, more than half of the shootings in the city at that time were in fact individuals who had various mental illness problems. Unfortunately for me, during the same time, I was president-elect of the American Psychiatric Nurses Association. I was mortified. I was devastated that this could happen in my town. And we mobilized the family and others, next slide, to take on this ongoing battle. And you can just hit these. Because as I discovered, Errol and Urana were very small numbers compared to the hundreds that this happens to every day, every year. I can't stress enough, next, that across the nation, it's as if there's some level of acceptance that this happens to individuals who actually need a very different kind of help. Locally, what we did was to move, next slide, on getting better education for our police. Janine Lokes, who is also part of the American Psychiatric Nurses Association, and in California has worked with Rotary and the Mental Health Association of Orange to develop a program where she actually took the post-training, she took the crisis intervention training, she took everything that the police say they do to prepare for these kinds of emergencies, and then modified interventions in a series of videos that we made available to the entire county, to every police officer. We were able to acquire a psychological emergency response team, people that go out with our police. But you're going to be talking today about something that is so important, giving family options. Imagine what could have happened in these 2 cases if 988 existed. Imagine how we could help so differently. Imagine that this tragedy may not have had to occur at all. Thank you so much. I want you to really think about these issues as you go through today. And if nothing, remember Errol and his family and the tragedies that occur around the country every single day. Thank you so much.
Thank you very much, Marianne. That was very compelling. I'm Erin Bagelman from the HHS Office of the Assistant Secretary for Planning and Evaluation. I have the privilege of introducing 4 wonderful speakers for our session on the 988 Lifeline Potential and Implications for Crisis Response. First up is Dr. Anita Everett, who is the director of SAMHSA's Center for Mental Health Services. Dr. Everett?
Thank you. What a compelling story, and really tough on many levels act to follow. Fortunately, for the good or the bad, our nation in many communities has focused attention on what we want our emergency response to look like. Typically in communities today, if you dial 911, you have the 911 system is set up to provide one of 3 options: police, emergency medical services, or fire. They're not really set up for the most part to respond to mental health services, although a good proportion of their calls relate to mental health emergencies. And so in recognition of that, or with increasing awareness on that regarding our national emergency response, Congress has set up the 988 Act, which by a year from now will mean that all telephone lines, cell and landlines from anywhere in the United States, if you dial 988, you will be connected to what is currently known as the National Suicide Prevention Lifeline. We're going to be talking with you a little bit more about some of the details for that. But broadly, we're very proud to be part of and to be, in fact, leading the response to organize services around 988 so that we have an adequate response. Let's go to the next slide, please. The Center for Mental Health Services, which is the center that I direct within SAMHSA, which is an agency within HHS, has four broad areas. This relates to our thinking about if we had a magic wand, so to speak, and we could, initiate, what would it take to lower the chronically rising suicide rate that we have nationally? These are our four main sort of buckets that we are interested in working on. The first of these, which is really what we're going to be talking about today, is bringing crisis services into the 21st century, the century that we're now in, modernizing our 988, our national mental health and suicide prevention response, so that our entire public mental health system and mental health system at large is much more responsive to the needs of individuals. Other concepts that we have addressed through grant series and other activities that we feel like could work together to address our national suicide problem. I think it's fair to call it a problem. Involves expanding zero suicide, which is a set of grants that typically are provided to healthcare systems. So individuals that touch the healthcare system in one way or another have idealized suicide capacity to address and also manage suicide. One of the things that's interesting about suicide from a planning perspective is that it involves public health as well as health delivery. You can't address our national problem with suicide unless you address both of those components. So the third of these has to do with assuring that more healthcare providers in the primary care realm, as well as specialty providers, are well equipped to manage suicide when it comes up, to identify and address suicide. And then the fourth of our four sort of wishes, activities, is some more local actionable data. We think that counties and local governments are very much have an important role with regards to suicide prevention. We note that, in the observance of counties side by side with similar demographics, that have some counties been able to really address and reduce their suicide rate, whereas others have persistently high rates. And so we're very interested in that. So I want to close by saying, the first of these priorities is really what we're here to talk about today. We see the crisis services as having three components: the call, mobile response for those who need that. You could envision an alternative response to the scenario we just witnessed in the video, the compelling video. And then the third of these is a place to go. So someone to talk to, someone to come, and a place to go, or the vision that we have. And today we're going to be talking about the someone to come to talk to component. So thank you. Now what I'd like to do is turn over to my colleague within SAMHSA, Dr. Richard McKeon.
Thank you very much, Anita. Much appreciated. And thank you to the National Academy for sponsoring this and for everyone who has been involved. I'm going to try to go through a lot of material currently, quickly, regarding where we are with 988. So one important thing, as Anita mentioned, is that 988 will build on the structure of the National Suicide Prevention Lifeline, which since 2005 has used the number 1-800-273-TALK or 1-800-273-8255. Every call to 988, whether made on a landline, a cell phone, or a voice over internet device, will, by order of the FCC, be directed to the routing structure of the National Suicide Prevention Lifeline. So unlike 911, 988 calls will all be directed to this structure as opposed to being dispersed locally, which is an important differentiation. Now, so what happens when you reach the National Suicide Prevention Lifeline currently, and what will continue to happen with 988? When you call, you hear a recorded message, and that message basically tells you that if you're concerned about a veteran, or you are a veteran or a service member, you can press 1. And in that case, you are connected to the Veterans Crisis Line. And you'll be hearing more from Lisa Kearney later on. There's an option to press 2, which is on the recording in Spanish. If you need to speak to somebody, if you need to speak to a crisis counselor who is fluent in Spanish. And then if you do not press 1 and you do not press 2, then at that point, the call is distributed to one of 184 local crisis centers in all 50 of the states, as well as in the territory of Guam currently. If the call is not answered within the first couple of minutes, the call will go to a backup center. So the Lifeline has a series of backup centers. This is a feature that 911 actually does not have. So that's the basic structure of the Lifeline. The Lifeline also has a chat service, and it has a small text service. Now, regarding the current status of 988 implementation, as Anita mentioned, by July 2022, every cell phone, every landline, every voice over internet device needs to make 988 operational. Although most cell phones currently do have made 988 operational, but most landlines have not. So if you're like me and you have Verizon, if I call on my cell phone, it will, and I dial 988, it will connect. If I call on my landline, it won't connect as of yet, but will by July 2022. Also, the FCC is currently doing a process, what they call a further notice of proposed regulation, looking at enabling texting to 988. So right now, if I use my Verizon cell phone, I can call 988, I can't text to 988. So we view this as Anita indicated, really as a once in a generational opportunity to improve mental health crisis services in America, both by expanding access, by more people being aware of and connecting to 988, but also by being able to link to a more coordinated system, including mobile crisis and crisis receiving and stabilization, the kind of system envisioned in SAMHSA's national guidelines for behavioral health crisis care. SAMHSA has already taken several steps to move in this direction. These include making a grant award to Vibrant for the next 5 years, using COVID funding for a supplement, and the president's budget quadrupled the request for the National Suicide Prevention Lifeline from $24 million to $102 million. SAMHSA is also working on the development of a comprehensive roadmap for 988 implementation, including providing more guidance for crisis centers, for states. There's the important issue of making sure that tribes are included and are able to receive the kind of crisis services that are important. And also to look at some of the important areas in the awful, tragic video that you saw. Coordination between 988 and 911 will be really important, so that somebody that over the phone or with mobile crisis, if the police are not needed, that a mental health team can go there, will also be very important. Also, the public will need to know when to call 988 versus 911. So these are all really important areas that we are are working with. And if I was on top of everything, I would be absolutely 100% sure on who's coming next. But I believe it is my colleague, Madeline Gould, who will be talking with you about the incredible series of studies that she has done looking at the effectiveness of the National Suicide Prevention Lifeline. So if I'm right about that, Maddie, take it away.
Okay, thank you. The first slide, next slide, please. Thank you. So national crisis lines were first highlighted really as recently as 2012 in the 2012 National Strategy for Suicide Prevention. And they've continued their prominent position in the 2021 Surgeon General's call to action to implement the National Strategy for Suicide Prevention. However, in 2001, when the first national strategy was published, suicide crisis lines were not part of the strategy. They were noticeably absent. And that's because the evidence base for crisis lines effectiveness was considered insufficient to include them in the strategy. And the major milestone that occurred in 2001 was the funding of a national network of local certified call centers by SAMHSA, and that this is now the lifeline that Richard McKeon just described. Next slide. And since the inception of the national network, there has been the evaluation studies that SAMHSA has been funding really continuously through different mechanisms. And what I'll be describing today are the findings from the evaluation studies that we conducted during the past 20 years. And what's really unique to these evaluations and the relationship with SAMHSA and the Lifeline is that these evaluation findings have been used to shape best practice standards across the network. And then these practices in turn led to additional evaluation studies. And so that's what we've meant by this very fruitful iterative process between the evaluation findings and practice. Next slide. So I won't be describing the details of any of the individual studies, but rather I'll be presenting major findings from now this whole series of studies. And prior to the Lifeline evaluations, there was a pervasive impression that callers to crisis hotlines were not seriously suicidal individuals. And the evaluations dispelled what was essentially a myth by demonstrating that seriously suicidal individuals do call the Lifeline, do call telephone crisis services. And that what we found in our first evaluation is that callers' suicide risk, for example, the caller's intent to die, is significantly reduced from the beginning to the end of the call. Studies have also found that counselors at Lifeline centers are more likely to inquire about current suicidal ideation, recent ideation, and past attempts, and that callers are more likely to experience reduced distress if, again, at Lifeline centers in comparison to some centers that are not part of the network. So our original studies did show this reduction in suicide risk during the call. Next slide. We then started focusing on callers who were at imminent risk of suicide. And we found that crisis counselors are able to secure the caller's collaboration on an intervention on over 75% of imminent risk calls. So unlike the very, very disturbing video that we saw, when you call the Lifeline, even if you are at imminent risk of suicide, you will be able, the crisis counselors can collaborate. They know how to collaborate with someone who's at imminent risk. What we did find that on about 19% of imminent risk calls, counselors did have to send emergency services, but they did so with the collaboration of the callers. There was an additional about 25% of imminent risk calls where the callers did have to send emergency services without the caller's collaboration. so that overall about 43% of imminent risk calls involved emergency services. Next slide. And what I mean by the collaborative interventions not involving emergency services, they include helping the caller get rid of lethal means, including a third party, someone else, family or friend who might be around, collaborating on a safety plan, agreeing to receive a follow-up from the crisis center. And as Mary Ann Nyhart had mentioned during her presentation, family members and friends often call on behalf of someone who they're worried about. And these folks who are calling on behalf of someone else are termed third-party callers. That's who I mean by third-party callers who call the lifeline. And, we've done evaluation studies that have focused on what types of interventions can be carried out with third-party callers to protect the folks who are at imminent risk. And that what we found is that the counselors are able to provide a large range of interventions which actually can supplement and at times replace calling 911. So sometimes they do have to call 911, but at other times they can do other, these other interventions, including getting the third party to help the person at imminent risk to the hospital without calling an emergency service. We've also done evaluation studies that have shown that follow-up calls from the crisis center does reduce suicidal individuals' perceived risk of future suicidal behavior. Next slide. And so I think we were mentioning in earlier presentations that to increase access to crisis services, Lifeline services now have evolved to include not only telephone, but also crisis chat interventions and text. And in our evaluations of chat, and this is a study now that's in press, we found that almost 84% of people who chat endorsed either current or recent suicidal ideation on a pre-chat survey, which is markedly higher than the estimated 23% of Lifeline callers who are suicidal on the day or the day before their calls. So that folks who are reaching out via chat are of are particularly heightened risk. And that our findings have shown that 2/3 of those folks who chat reported that the chat was helpful and that they were significantly and substantially less distressed at the end of the chat intervention than they were at the beginning. And this research, involved over 13,000 linked pre and post chat surveys. And that we also found that about half reported being less suicidal at the end of the chat. Next slide. And so the, series of evaluations have found, that counselors can do suicide risk assessments, can reduce imminent risk, sometimes with, but often without calling emergency services. And now we're finding that chat also is an effective intervention. And so our country really is ripe now for 988. We know that the services are effective, but that I do want to just end with some questions that we will need to address in future evaluations. These questions are based on findings that, I didn't go into every nitty-gritty detail today with regard to our findings, but some of the things that we will have to continue to evaluate is how are imminent risk calls, chats, texts to 988 resolved? And these questions include, to what extent is imminent risk reduced during the course of the crisis intervention without needing additional emergency services? How often are 911 or police called by Lifeline crisis centers? How often are mobile crisis teams and stabilization units used? And then to what extent is information shared between Lifeline crisis centers, 911, EDs, and other crisis and service emergency services. Because as we think about a systematic, or a mental health crisis, suicide crisis system of care, all of these services are going to need to collaborate and share information. And with regard to outcomes, we'll need to examine what are the outcomes that emerge after different types of dispatch in terms of, whether it's 911 or 988 or sending to a mobile crisis team, and what types of outcomes emerge after different types of information sharing. And then very importantly, and that will be discussed, in another session today, is do dispatch and outcomes vary for different risk groups, for different ethnic and racial and gender groups? And so that as we go forward, the evaluations, do need to continue to make sure that, 988 is as effective as possible and as effective for every different type of, person, no matter what their background. And so thank you for, giving me the opportunity to share the findings. And on the next slide, if people want to know where these findings are coming, I've provided a list of the citations as well. Thank you.
Thanks, Maddie. I always love listening to you and hearing all the results of your wonderful work, which have informed us over in the Veterans and Military Crisis Line as well. So thank you so much for that. Next slide, I want to talk a little bit about kind of our current kind of call volume, what we've been seeing and what we're preparing for with 988. So since the onset of the Veterans Crisis Line back in 2007, we've fielded over 5 million calls. And over the years, we've expanded our services, just like our Lifeline partners, with text and chat. And I want to talk with you a little bit about not just answering the call in the moment, but what do we need to do to prepare for 988 beyond the call? What happens in support after the call, after the chat, after the text, and how can we work with all of you across the community to help ensure follow-up services for veterans and service members in particular? On average right now, we're just a little bit below about 2,000 calls per day, and that's a chat and text are on top of that. So next slide, I wanted to talk with you about 2 initiatives we've started also, which is coming in alignment with preparation for 988. One is caring letters, and we know this is an evidence-based program in which individuals who are in crisis have follow-up letters at set intervals to connect them with resources and provide them information about support, which has actually been shown to help reduce rate of suicide death attempts and ideation. And it's been published in our VA DoD clinical practice guidelines around suicide risk. One of the things that we have worked to do is particularly it aligned well with the onset of the pandemic, was really trying to reach and connect people to support after they reach out to us at the Veterans Crisis Line. So we've actually reached over 100,000 veterans in follow-up from their call to us, and are currently in active evaluation of this project used within a crisis center, which is a little bit different than some of the prior caring letters projects that are reviewed in our clinical practice guidelines. The other thing that we just launched, which I am very excited about, is our peer support outreach call center. So after individuals call us, we can connect them with peer support for several calls while we help engage them in follow-up care, either in the community or within the VA healthcare system. And so that just launched this past month, because it's not just about getting people help within the moment of crisis, but getting them care, resources, support afterwards to help them engage in follow-up. Next slide, we'll cover a little bit further kind of information. This is building off of Maddie's wonderful work. We've also done significant evaluation of Veterans and Military Crisis Line. I wanted to highlight a few things, just as Maddie was indicating concern. We know that individuals who call our crisis line are at much higher risk for suicide. And that's with our annual report data where we're tracking veteran suicide. So we need to ensure services after the call and engagement after the call. We also have found similar findings to Maddie's, which is less distress from beginning to end of call, reduction in suicidal ideation, reduction in suicidal urgency. We've also had satisfaction data related to this. And really importantly, is veterans are more likely to engage in care, both in mental health and primary care, after calling the crisis line. And so those are significant findings that we want to continue to build off from. And we're currently expanding our evaluation efforts also with emergency service dispatch and other data. And Maddie, I look forward to continuing to talk with you and learn from you and others on this call who are doing evaluation work. Next slide really talks through a little bit further about what we see as 988 impacts. So looking at, we've done studies and done Monte Carlo forecasting models based off of what happened in England when they went to a 3-digit call number. We know and expect increased call volume, but also the need for collaboration and coordination after the call. And so we are looking at not just the expansion that's needed in the crisis line and other crisis lines around the country, but how will that impact our mental health service system in VA and outside VA, as we know that we will get increased referrals for our inpatient care, our residential care, PTSD treatments. So trying to work together to prepare the system as a whole. We also have project management teams across clinical operations, increasing our quality assurance monitoring, the IT infrastructure that's going to be needed to support this, and bringing that together across the team. Next slide. I'd like to kind of follow through of these are items that Richard already covered, but again, reminding people 988 is not going to be fully available until July, though we have some service carriers there. And next slide, I will just end with this thought for you, is trying to help us think through what do we need to do together in our systems to embrace this new future. To me, 988 provides us additional options to get individuals to care and support. So I think we need to think about how do we shape offload demand? How do we increase and maximize capacity of our mental health service system, both within VA and with all of our community through other options as well. And so it's not just looking at our crisis centers, but our systems as a whole. Thanks so much for having me on. I look forward to our ongoing dialogue.
Thank you so much, Dr. Kearney, for presenting this compelling information and for setting us up with some compelling questions to bring us to the next steps. My name is Matt Tierney. I'm current president of the American Psychiatric Nurses Association, and it's my great pleasure to introduce the next 3 speakers in today's webinar. The next section is really going to discuss various issues on 988 rollout, including privacy, confidentiality, and equity considerations. As with other aspects of this webinar, it's going to be pretty quick at this point. Each speaker is going to have about 5 minutes. And as Dr. Rory pointed out in our introduction today, it's going to feel a little like speed dating. So without further ado, I'd like to introduce Sue-Ann O'Brien, who is Chief Executive Officer of Behavioral Health Link, and she's going to present their experience in the state of Georgia. Sue-Ann?
Great. Thanks, Matt, for the introduction, and thanks for having me here today. Really excited about this opportunity. I've been saying all along, it's one of the most exciting times to be in the field right now with the advent of 988. It's definitely really transformational, to use Richard's word, in terms of how it will change the landscape of addressing people that are in a behavioral health crisis and getting people connected to care. As Matt said, I'm CEO of Behavioral Health Link. We're located in Atlanta, Georgia. We operate the Georgia Crisis and Access Line, which is it's one statewide hotline number for people in crisis, and it's a single point of entry into the entire crisis system. This year, we're on track to answer more than 250,000 calls. We do text and chat as well. But you know what happens when you have calls coming into one line, which, as you heard Dr. Everett talk about, the 3 components of the Crisis Now model. having, someone to call, someone to come to you, and somewhere to go. When you have all the calls coming into this one number, you need to have a full continuum of care in order to get people connected to the right type and the right amount of care. And so having a full continuum of crisis services is going to be super critical with the advent of 988. Of course, the predictions are that call volume will drastically increase with the ease of the 3-digit number. And that's a great thing in terms of accessibility and hopefully decreased stigma as well. But we will have to have those other services in place. When you don't have a full range of options, what happens is you have an over-reliance on 911, and that usually has 2 options, which is police or ambulance, as we unfortunately saw in Mary's video at the beginning of the session. And those 2 responses, end up with 2 results, either jail or emergency department. And of course, we know that these adverse outcomes are exponentially more likely for people of color. So as this session is about equity, as a portion of it, I've been really thinking a lot about the workforce that is needed to staff up to meet the demand of the increased volume around 988. And not just the sheer numbers of staff that are needed, but also the composition of the workforce. This can't be just licensed clinicians. We're already facing a workforce shortage. And we know that the vast majority of the behavioral health workforce in this country is, by some counts, around 85% Caucasian. Conversely, the number of non-white citizens in this country is approaching 50%. And more than 67 million residents speak a language other than English in their homes. So this got me thinking about the class standards. Remember the class standards? This was the culturally and linguistically appropriate services put out by HHS Office of Minority Health in the year 2000 with an update in 2013. This was a set of 15 recommendations for healthcare agencies that was really intended to advance equity and to eliminate healthcare disparities for healthcare organizations. One of the recommendations is around having a workforce that proportionately represents the population that's served, which I think is an issue that a lot of agencies have been taking a look at, especially with the recent and ongoing civil unrest and racial injustice. And I, of course, had those same questions about BHL. I mean, we're located in downtown Atlanta, where African Americans account for 51% of the residents there. And I was curious about whether what the composition of our call center workforce was. Taking a look at that, our workforce, specifically on the call center side, is comprised of 77% of African Americans. Given that African Americans comprise more than half of the residents in Atlanta, you might think at first glance that this is pretty great. But the issue is that when you get outside of Metro Atlanta, this sort of flips. The population outside of Atlanta is quite rural. It's a vast state with 159 counties. And the population is more than 60% Caucasian. I'm going to guess that this is true. It's the same dynamic at play for several other major metropolitan cities in the United States. So why is this of a concern to us? We had a firsthand, that this was driven home for us a few weeks ago with a firsthand experience we had. I'll just share with you really quickly this story to make my point. But we had a caller to the hotline. He was a Caucasian male, mid to late 50s, in a very rural Georgia county. He called the Georgia Crisis and Access Line, reported to the call taker that he was sitting in his pickup truck with a rifle, contemplating taking his life. The young lady that answered the phone, behavioral health link employee, she was a 25-year-old African-American licensed clinician, very well-trained, good at what she does, had worked for us for several years. She really struggled to connect with him. And of course, he was really struggling to connect with her as well. So I share this because it's not just an issue of race, it's an issue of culture. And I think what's needed here is more of an emphasis on cultural humility. Cultural humility is defined as the ability to maintain an interpersonal stance that is open to the aspects of cultural identity most important to the person. If we can't bridge this divide, it might indeed be a matter of life and death. It's imperative that we leverage a well-trained, diverse, and even non-clinical workforce, including peer support specialists, if we are truly going to address the equity issue head on.
Sue Ann, what a great note to end on. Thank you so much for your contributions and for bringing these topics up. Next, I'd like to introduce Pamela Endofhorn, who is a national suicide prevention consultant and who, with Indian Health Services, has worked with the Division of Behavioral Health in the Office of Clinical and Preventive Services. Pamela?
Thank you, Matt, and thank you, Sue Ann. So today we want to talk about patient-centered care, which really falls into line with what Sue Ann was just saying in regards to culture, cultural humility, and how do you work with patients who are from specialized populations, special populations, such as American Indian Alaska Natives and veterans. Next slide, please. So Indian Health Service, we provide health care to 2.2 million American Indian Alaska Natives across 37 states in the contiguous U.S. and Alaska. So we focus a lot on the culture of each tribe. And a lot of times people akin IHS to the Department of Veterans Affairs in that we are a system, a healthcare system. But the reality is when we're looking at IHS, we're actually healthcare systems. We work in partnership with tribes because tribes are sovereign nations when you look at them from the perspective of the Constitution. Each tribe has a treaty, and as such, the U.S. government has tribal and treaty trust obligations to those tribal nations. And so as we work with these cultures, and over 500 different individual unique tribes, we have to go where they are. And when we speak about equity within healthcare, what are we talking about? We're really talking about providing the healthcare that is needed, when it's needed, and how it's needed. So how do we do that? We do that from the perspective of humanization within healthcare, patient-centered care. By looking at the patient within our healthcare system, providing them what they need in regards to their healthcare. How do we do that? We do that by accepting them, by assessing and identifying from their perspective and understanding the patient and empowering the patient to go where they're going. And we do this through altruism, empathy, respect. Next slide, please. So when we look at American Indian Alaska Native communities, tribal communities, we really have to go with what they themselves need. Many times within tribal communities, the act of sharing stories is seen as medicine. So giving the opportunity to the tribal nation, to the person within that tribal community and tribal nation to share with you as a provider what's happening to them, what they're experiencing. Because what they're experiencing may be very different from what other patients within healthcare systems in Western medicine it could be experiencing. A wonderful example, which comes out of the Navajo Nation, is most of the time they provide translators to patients within their healthcare system because a large percent of their population speak Navajo, Dene, as part of their day-to-day life. And so when they're receiving healthcare, having that spoken language is an integral component to ensure health equity. Again, giving the treatment that they need when they need it and how they need it. And what Native people do is we often share through stories. This is what's going on. This is how this happened. And giving that Native person the ability to communicate, to share through narrative therapy, evidence-based, and talk about the influence of the culture, the tribe, and how those two pieces, holistic medicine, traditional practices, can meet Western medicine to provide care that is culturally humble, culturally aware, and culturally appropriate. Next slide, please. So what do you do? Often, this is a question I'm asked. What do we do? How do we do this? What do we need to do? It really comes down to capacity building. This is the difficulty, and this is why IHS, we like to say we work in partnership with healthcare systems. We work in partnership with the tribe. We do this through strong representation within Native communities. We build community-based interventions and education and go where they are, in the means that they need, in the mechanisms that they're requesting. We network, we do intensive outreach, and we implement our services in equal partnership. In fact, most of the time it's the tribe who's driving the services. This is what we see as equity within healthcare. This is what we see as providing culturally humble, culturally aware services in the context of Western medicine, and pulling in those tribal traditional practices and understanding that how that patient is presenting, they're presenting in their own unique way that's based in tribal nation, based in tribal cultural, tribal community, as well as tribal ethnicity. All of those pieces have to be presented when dealing with the situation and providing services. Thank you for your time today. And with that, I will hand it over to Victor Armstrong. Thank you.
Thank you so much for having me today. Let me start by saying that I see 988 as a tremendous opportunity. 988 affords us the opportunity to create a system where equity is the foundation rather than an afterthought. And when I talk about applying the lens of equity to mental health, I'm not just talking about equity as it pertains to race, culture, and ethnicity. The lens of equity is about the intersectionality of race, culture, and ethnicity, in addition to living with mental health challenges. It's about being Black and living with a serious mental illness. It's about being Latino and living with intellectual disabilities or traumatic brain injury. It's about being Native American and living with a substance use disorder. It's about being an Asian trans person struggling with an anxiety disorder exacerbated by the discrimination that often accompanies mental illness, the hatred that is perpetrated toward trans Americans, and the increasing rates of violence against Asian Americans. It's my contention that the very construct of our current mental health system is flawed, beginning with our response to individuals experiencing mental health emergencies. Our current system was not built from the perspective of individuals with lived behavioral health experience, nor was it designed to address their mental health needs. I would argue that our current system is not designed to protect and nurture the individual experiencing the mental health emergency, but to protect the rest of us from the individual experiencing the mental health emergency, and that is wrong. The introduction of 988 will provide us an opportunity to mitigate those challenges and to correct that wrong. For many people of color, the introduction to the behavioral health system ends up being in the back of a police car or in an acute care emergency department because they do not have access to outpatient services or crisis services in the communities where they live. We cannot ignore how a person of color enters the behavioral health system. Research indicates that Black adults are 20% more likely to report psychological stressors than our white counterparts, but we are less likely to enter treatment and more likely to terminate treatment prematurely. Again, I believe that is in part because resources are not located in the communities where people of color live, work, and play. This makes it more likely that they will be introduced to the behavioral system when they are in a state of crisis. And arriving at the behavioral health system in the back of a police car or in an acute care ED is not conducive to good clinical outcomes, nor is it likely to foster a positive relationship with the mental health system. Remember, when we talk about suicide and suicidality, I'm often reminding people that suicide itself is not a disease, but it is the worst possible outcome of a culmination of a lot of very complex things. And that being the case, we have opportunities to intervene before an individual reaches the point of suicidality. But those interventions should be person-centered. Suicide prevention should be about more than detaining someone when they are in crisis. Yes, crisis intervention is about preventing a person from attempting to harm themselves or others. And yes, mental health legislation allows people expressing suicidal thoughts to be involuntarily committed. But assessing risk at the individual level or the community level involves considering not only risk factors, but also protective factors. If you don't understand or acknowledge the impact of cultural beliefs, including stigma and relationships with law enforcement, or the impact of structural racism on my life and my perception of my place in America, your intervention may in fact become another traumatic experience that I have to carry. Building cultural humility in our system via 988 will increase the likelihood that individuals receive care in the communities and that they receive care that accounts for the intersectionality of race, ethnicity, culture, and sexual identity. Systemic racism and bias, both explicit and implicit, are multi-layered and seep into every crevice of society, including law enforcement, schools, healthcare. The mental health system is not immune. When we know that inequity exists, it is our moral responsibility to address those inequities by leaning into equity in every decision that we make as clinicians, policymakers, or simply as change agents. Either leans into creating a more equitable system or perpetuates inequity, and 988, again, is our opportunity. According to the Washington Post police shooting database, 5,772 people have been shot and killed by a police officer in the line of duty since January 1st, 2015. Nearly 1/4 were African American, with the vast majority, almost 97%, Black and male. And police killed Black Americans at more than twice the rate of white Americans, 33 per million, compared to about 13 per million, respectively. People in mental health crisis are also highly at risk of death during a police interaction. In fact, 23% of people killed by police were identified as having a mental illness. And that's not to impugn police officers, but to merely suggest that there's a flaw in our system. And when you have African Americans whom, under the best circumstances, disproportionately have bad outcomes in encounters with law enforcement, and then you add the additional risk factor of being in a state of psychosis or suicidality, where the individual's behavior is likely to be more chaotic, erratic, and incoherent, you have an increased likelihood of a negative outcome. 988 can be a spark to dismantling racism in our mental health response system and a building block in creating a system that is more equitable by supporting the creation of more mental health resources in communities of color and underserved zip codes. These resources can include mobile crisis, facility-based crisis, peer respite, and any number of resources designed to divert individuals away from emergency departments and jails. We can create more community-based resources that provide access to upstream treatment, rather than continuing in the crisis response mode that we have existed in for the past several decades. We can seize the opportunity to build a workforce that mirrors the populations served. Currently, while African Americans comprise roughly 13% of America's population, only about 4% of American psychologists are Black, and only about 2% of American psychiatrists are Black. We do, however, have a ready-made but underutilized workforce of individuals with lived behavioral health experience, Black, white, Latino, Asian, and Native American. Right here in North Carolina, we have roughly 4,000 trained, certified peer specialists with only about 1,600 gainfully employed. We need to utilize the peer workforce, pay them a living wage, and build them into our crisis continuum to respond to individuals experiencing mental health emergencies at a time when they most need someone who understands their immediate challenges. We can increase the percentage of historically marginalized populations receiving behavioral health services by building and earning trust between historically marginalized communities, behavioral health providers, and funders as we bring them to the table in planning our 988 model. By seizing this opportunity to work with community partners, community media, and grassroots messaging to educate communities, combat stigma, and address concerns about receiving mental health treatment. And by leveraging expertise of providers of color who have traditionally served historically marginalized communities, often without access to government grants and contracts, and engage them in the planning. By giving voice to those who lived experience, we can reimagine our approach to behavioral health. With the intersectionality of clinical expertise and the voice of historically marginalized individuals, our approach will be ill-advised, ill-informed, and ill-fated if we conduct ourselves otherwise. As we have in the past, we can speak with the opinions of intellectuals, the desires of legislators, and the needs of the majority, potentially creating a system that may work for 80% of the aggregate population in need, but could potentially not address the needs of 80% of the Black population, the Latinx population, or the Native American population. If you have not lived the life experience of those you seek to assist and don't have decision makers with that life experience at the table, you cannot fully understand the challenges and address the need, no matter how well-intentioned you may be. Historically marginalized communities, whether marginalized due to race, ethnicity, or diagnosis, are not looking for a rescuer, not looking for a savior, and not looking for a handout. Historically marginalized communities are looking for a collaborative partner who will value their expertise and life experience. Believe me when I tell you that those living with mental health challenges, those struggling with addictions, and those living with intellectual disabilities or traumatic brain injuries are themselves a historically marginalized population. And they're not looking for a voice for the voiceless. They're looking for an opportunity to have their voices be heard. We have, through 988, the ability to build a more equitable system, a more responsive system, a system that is not only evidence-based and evidence-informed, but community-informed, lived experience informed. And my life experience tells me that if we don't build equity into 988 on the front end, the most powerless and vulnerable among us will not receive equity, justice, or access to the mental health resources they need and deserve. Thank you.
Thank you, Vic. Another great panel, of course, and the efforts to describe the huge need for this, for competent services, the challenges. And now we want to focus on some experts who know some communities or underserved populations and can provide some suggestions about how to make this, how to kind of reach Vic's dream here of making this right from the beginning. So I think we have like 9 folks to walk through. They can have their cameras on or not. I will try to quickly get folks started. And this is truly the speed dating part where you've got 5 minutes. So first up is Mei Ye, and let's just go and I'll just announce the next person as we go.
Great. It is such a tremendous privilege to be part of this workshop and this session. I want to be upfront with you that I'm not an expert on crisis intervention or on suicide. However, I've been heavily involved in research on racial ethnic disparities and cultural competence issues for many years. I'll be sharing a general framework that our team has proposed for developing personalized, evidence-based interventions for culturally diverse populations. We hope that some of this work may provide some considerations as planning for 988 moves forward. The framework I'll be presenting is called the person approach, and you can go to the next slide. We've applied this approach to the development of a personalized version of an existing evidence-based treatment for disruptive behavior problems in young children through research supported by the National Institute of Mental Health. Theoretically, the framework can be applied to any intervention or cultural group. In this approach, we propose that interventionists personalize an existing evidence-based intervention by taking 3 steps. 1, identification of factors or dimensions. 2, development of an assessment. And 3, development of personalization tools. I'll overview each step very briefly here. First, identification involves understanding potential dimensions upon which personalization for culturally diverse populations may need to occur. This is an absolutely critical step because individual providers may not be aware of the different cultural dimensions that may affect care for any given caller. As such, it is important to ascertain factors beforehand that may be highly influential for the cultural groups for which the intervention is targeted. This was done in our work by finding factors or dimensions that 1, had research showing a relationship to clinically meaningful outcomes, 2, have variability across cultural groups, and 3, can be addressed through personalization. In our case, the clinically meaningful outcomes related to treatment engagement and treatment outcomes. In the case of suicide prevention, perhaps these clinically meaningful outcomes might relate to service use, engagement with the intervention, or suicide-related ideation or behavior. The types of cultural factors that may be relevant may vary based upon the clinically relevant outcome. For example, when considering barriers to using mental health services, perhaps stigma or concern about loss of face may be a stronger barrier in certain cultural groups, while perhaps mistrust of service providers, access, or knowledge of services may be a more important barrier for another. When assessing risk or protective factors for suicidal behavior, Joyce Chu and colleagues indicate that in addition to factors such as depression, reason for living, and hopelessness, it may be important to take into account cultural factors such as family conflict, social discord, acculturative stress, minority stress, cultural sanctions related to suicide, and idioms of distress. These are just some of many possible examples of factors that may be important to examine related to suicide prevention outcomes for culturally diverse populations. Ascertaining clinically and culturally relevant dimensions may require further research, literature review, and consultation with experts, community members, and leaders or other stakeholders. Identification of these dimensions is a critical first step. The second step of the person framework is focused upon finding brief ways to assess the components that were identified in the first step. This step of assessment is here due to the recognition that groups are heterogeneous. It may be possible that certain factors may be more salient for certain individuals within a particular group, or may also apply to others outside of that group. In addition, people may also affiliate with more than one cultural group. Developing assessments for the specific dimensions or factors allows us to broaden the ability of the intervention to respond to different groups while also individualizing the treatment protocol to the specific person. Results of this brief assessment give service providers a sense of factors that may be especially important to address with a particular individual before they begin the intervention. I can imagine that if this approach were applied to crisis intervention, the brevity of the assessment may be especially important, balanced with the ability to assess the most important specific factors or dimensions. In the third step, tools or adaptations are developed beforehand that would address the dimensions or factors identified in the first step. For example, one tool may be developed to address the potential risk factor of family conflict, while another may be constructed to address minority-related stress. Developing the tools beforehand for the array of possibilities gives providers a toolbox of what they may need to address important factors and also increases the likelihood of being able to train providers in effective delivery of these tools. After the personalized intervention is developed, it is used as follows. The brief assessment can be given before the intervention begins, and the tools or adaptations are triggered and then implemented to personalize the intervention based upon the results of the brief assessment. The hope is to provide a culturally responsive intervention that takes into account important cultural dimensions while making it possible to standardize the delivery of tools and personalize the intervention to an individual when implemented. We believe and hope that developing personalized, culturally responsive interventions for culturally diverse populations is possible. I'm very excited to be learning from the speakers in this workshop about the types of factors, assessments, and tools that are important to consider as 988 moves forward in the effort to make it more culturally responsive.
Great, thank you. What a great framework. Pamela Endehorn, you're up again.
Thanks, Jane. So beyond cultural competency, let's talk about this. Next slide. So when we're looking at culture, it's a value-laden term. Values are cultured. A lot of times we throw around the word culture. What does it mean? Well, anthropologically, there's really no set definition. But what we do know about culture is that it's defined through three meanings. It's a group of people who belong together. It's a systemic organizer. And it really comes down to the term belongs to how the person and the environment are interrelated. So culture isn't just systemic beliefs. It isn't just practices or knowledge. It's what belongs to a group of people and who and what that group of people belong to. This is very important because as we're talking about Native Americans, American Indians, Alaska Natives, often the groups are labeled as Native Americans. We are lumped into this one group. And that really takes away from the individualization and the uniqueness of each tribal nation. And it really brings into play what's called pan-Indianism, that all Native Americans are the same. We all have the same belief systems. We are all one nation, one tribe. The reality is, though, is that we're all very different. We all speak different languages. We all have different culture and creation stories. We all have different songs, different belief systems, different kinship and family structures. And so when you're thinking about culture, you have to think about it. What is your lens and how are you viewing culture? Because often how you were taught to view culture is what you utilize when you're thinking of other cultures in the context of your experiences. Next slide, please. So how do you do this? What do you do? A lot of times, it really comes down to three basic strategies. You can ignore them, and sometimes that happens. You can focus on the inter-individual differences, meaning that that phenomena between two people of different cultures is somehow stable, that somehow that doesn't come into play. It might be a portion of what the reality is if you're working with this individual, or You can focus on the intra-individual differences. You can expect that phenomena to change and to further change and to destabilize. And when we're looking at crisis services, this is key because you're dealing with an individual who's meeting you at a time in their life in which they are in crisis when they're having a bad day. And the reality is the culture from which they are reaching out from, that can destabilize as well. They are dealing with situations within their life and lived experience that is leading them to additional change. So helping them stabilize within that change and come to a realization or obtain of services to help them with that realization is what really we should be focusing on when we're talking about crisis services. Going to where the patient is, again, health equity, providing them treatment that they need at the time they need it in the way that they need it. Next slide, please. So why do we have to go beyond cultural competency? Cultural competency is one of the hallmarks when we think about healthcare. In fact, I'm a social worker. It's one of our core competencies. We have to be culturally competent. But the reality is that cultural competency is not a clinical skill. It is an opportunity for individuals to learn about local customs, local perspective, to build networks and incorporate those elements and aspects into the care that's provided, to allow the care to be responsive to the community felt needs and political patterns, especially when we're talking about tribal nations. Tribal nations change often in regards to administration and political patterns. And so providing services that is understanding of that and responsive to that will really go to where the patient is and what they need and provide equitable health care. And recognize and remember, culture is valued within the community and the care which is served within that community. So what care is going to look like in the Navajo Nation is going to look like different from my own tribe, which is the Oglala Lakota Nation in South Dakota. Those two healthcare systems are very different, and they have to be, because each tribal nation's reality is very different. And then sustain that dialogue. I cannot stress this enough. You have to go to the community and become part of that community in order to provide services. This is not something that the community should be coming to you for. This is something that you should be going to the community, inviting them in, building bridges, and working to understand their reality, and then incorporating that within your services that you're providing. Because no one person is going to be able to provide that. And in fact, I myself, standing here today speaking to you, I am one person from one tribe, and there are over 500 federally recognized tribes, and in addition to that, hundreds others who are state recognized. They all have different realities and are unique. So please consider going beyond cultural competency and seeing it as an opportunity. Thank you.
Thanks, Pamela. That was great. Thomas Chavez, are you on camera? Let's see. There's so many of us on this fast panel. There he is. Okay, you're on.
Do you want Thomas or do you want Jennifer? So this is Jennifer Battle, and this is my slide. So
sorry about that. I apologize.
No worries. We'll jump right in. So I am talking a little bit. I'm in Houston, which is Harris County, and I work in an actual crisis center. So I work at the Harris Center for Mental Health and IDD, which stands for Intellectual and Developmental Disabilities. So we are one of those 184 centers that you heard Richard talk about earlier, who is a proud member of the Lifeline family and will become one of the 988 centers moving forward. And so what I wanted to talk a little bit about is, of course, very similar to what you've been hearing from all the colleagues, which is, many of us live and work in very diverse communities. And yes, I would love to be able to have very specific training available on every single community that's represented in our diverse, not only my county, but the almost 60 other counties that will serve when 988 goes live. However, the likelihood that we'll be able to do that is slim. So that focus on cultural humility that you've heard Pamela talk about and that you heard Big Talk About is so key for us, because it really is based in this idea of we need to be able to serve as many people as possible in our call center, in our 988 call center, and then work collaboratively with the rest of the community and the rest of our state as far as those handoffs for care into any folks who need something else, something extra for us to connect them forward. So in our community, just Houston, Harris County in and of itself has almost 5 million folks. It's a really interesting place because 69% of people that live in the Harris County area identify as someone from a community of color. We have over 145 languages that are spoken, and almost half of the people that live in our county either speak another language or are bilingual, which is also really exciting as a community, but also terrifying from a call center perspective. So really trying to figure out how we can serve all these folks effectively is huge. A little bit different across the state of Texas, as you heard Sue Ann say about Georgia. Although Harris County is super diverse and has lots of different languages and folks across the entire state of Texas, we look at about 25% of people in the state of Texas identifying as from a community of color. So it does change depending on where you are in the state. So a big part of our 988 planning has included having actual real-time conversations as part of our 988 planning grants around the specific issue of equity at every single meeting. So when we talk about how do we actually utilize and work through cultural humility and work through equity in a way that is not just lip service, but in a way that is real strategic planning, has been very exciting. In fact, actually, Vic spoke to our stakeholder meeting yesterday and was very well received. And then after that meeting, we broke up into small work groups and talked about very specific issues around translation services, coming up with very specific strategies around what are we going to do if we have somebody who calls in and we're able to handle the call using either a native speaker on the line, or if we have to use a translation service, what happens if we have to connect that caller to something else, to a next place? And so where does the 988 sort of responsibility morph into what the community responsibility is, and how are we going to navigate those challenges? Also talking about the potential of doing some training for people at the companies that we use for translation services, because they may not have a lot of expertise or understanding around mental health care or suicide prevention. And so being able to provide some resources there to help support those folks who are helping support us and the people that are calling. And so for those of you who are not involved in your state's 988 planning grant process or our stakeholders, I really encourage you to reach out to your local crisis centers so that you can find out what's going on and see if there's anything that you can do to lend your expertise and voice to that process, or at least be aware of what's happening in your communities, especially if the work that you're doing has a strong equity lens. And our conversations at our state level have a lot to do, again, not just with equity lip service, but also really focusing on the idea that social justice work is suicide prevention work. The more that we can create a life worth living for people, the more that people are going to reach out for the care that they need when they need it, and hopefully trust us enough to be able to be the folks that they reach out to. And the last thing I want to say is please keep in mind that the knowledge of what's going on in the community, sort of like what Pam said, is so important to keep the local communities involved in answering your crisis lines. Local regional call centers are such a value. So please make sure you reach out to your local call centers and hear what they're doing and provide them some support.
Thank you so much. I'm sorry I messed up the order here. That was so valuable to hear, like how you're right in the middle of trying to move this out. So thank you. Now, Thomas Chavez, please, Go
Yes,
ahead.
thank you. It's an honor to be part of this series of works. My work has been supported through the Transdisciplinary Research, Equity, and Engagement Center. Next slide. The TREE Center's mission is to improve behavioral health equity by promoting multiple ways of knowing and the growth of transdisciplinary researchers, highlighting the context of history, culture, and their impact on behavioral health. Next slide. Here's some contact information, and I am speaking on behalf of the Center on Latinx Youth in the context of undocumented populations within. This includes youth who have been impacted by the DREAM Act and DACA. The Latinx population is the second largest racial or ethnic group in the US, representing about 60.6 million of the population. 4 in 5 of this population are US citizens. The Latinx community is represented by many diverse groups with most immigrants coming largely from Colombia, Guatemala, Honduras, followed by El Salvador, Cuba, and the Dominican Republic, with the least migrant population are Mexican nationals. One theory that is well discussed in discourses of Latinx well-being is the acculturation theory, wherein the longer an immigration stays in alliance with US values and health systems, the poorer their health outcomes are. The measure of acculturation must take into consideration affective, cognitive, and behavioral dimensions to understand its impact on health. We must ask about the strength of identification with and attachment to culture, the extent to which cultural values are held, and whether they maintain language and traditions, and how they relate to well-being among Latinx populations. Expanding the theory, we must consider the sociological systems that impact well-being. For example, did they come in as a child? Did they migrate as an adolescent or a young adult or adult? Different social attitudes and policies vary among minoritized groups and will vary from time to time and understand differently by each age group. Another contextual factor is the diversity of the destination culture. The less diversity there is in an area where they migrate to, the more likely the individuals of a minoritized status will experience stress. In particular, there are 2 types of acculturative stress, including the pressure to assimilate as well as stress due to discrimination. In regard to youth, acculturative stress is added to the already complex developmental stressors typical for this developmental stage. Anti-immigrant sentiment in society often coincides with bullying situations among youth groups. And so such stress may contribute to internalizing and externalizing behaviors. In regard to suicide, we observe that there are lower rates of suicide when compared to other ethnic racial groups. More likely, Latino youth are more likely to report suicidal ideation and attempts than non-Hispanic peers. There are elevated rates among Latina groups, in particularly coinciding with experiences of violence. And the expression of such experiences are quite limited. Often they experience oppression due to their gender. There are particular cultural expectations that are in discord with their acculturation. Latina adolescents may attempt suicide more so when there is a presence of poor psychosocial functioning and family crisis. And we also must consider elevated rates among LGBTQ plus Latinx youth, even when we're accounting for depression and substance use. Understanding the Latinx population has been limited due to theoretical perspectives, not considering their unique experiences. One example theory that helps investigators and practitioners understand such experiences includes critical race theory, which is a methodology for helping investigators maintain consciousness of racialized constructs and historical and socio-political mechanisms. Also, LatCrit or Latino critical theory allows investigators and practitioners to examine how multiple forms of oppression can intersect with the lives of people of color and how those interactions manifest in the daily experiences unique to the Latinx community, such as immigration status, language, ethnicity, and culture. And finally, on docu-crit theory is a critical lens to analyze how racist immigrant practices, policies, and rhetoric function to spread fear among undocumented population. One example using critical race theory is a study conducted by my team, where we found that among Latinx young adults and their families, they were living in constant fear due to fear of going to a healthcare institution and being reported to ICE, constantly being stressed due to financial and emotional issues, connected to lacking health insurance and having to pay out of pocket. This population largely depends on community health clinics for all their healthcare needs. Only do they seek emergency services where it's a life and death situation. Particular risk factors thus are experiences of discrimination, minority stress, exposure to violence and trauma, cultural issue gaps in families, systems, social and linguistic isolation, economic stress, and family conflict. Protective are pretty much the familism, the values of familism, personalism, and respect. Also involving parent in interventions, highlighting and promoting biculturalism, bilingualism, and expanding their social networks. We might focus on expanding social media campaigns to reduce stigma of mental health and substance abuse, promote safety and belonging, non-discrimination laws, for example, guaranteeing universal coverage for all youth, and implementing trauma-informed policies, keeping families together, promoting community resiliency. And also we might promote mental health, emotional well-being since early childhood, promoting anti-bullying and training and policies, highlighting evidence-based practices for Latino behavioral health, highlighting also cultural and linguistic prevention, and creating partnerships between family, community, and schools to promote resilience and healing trauma. Thank you.
Wow, those are amazing resources. Thank you so much. Dr. Jinxi Zhang, you're next.
Thank you. Good afternoon. First of all, I want to thank National Academy and the Planning Committee, especially co-chairs, for the opportunity to discuss building cultural competency. I want to echo my colleagues saying the importance of the equity which will be built in the 988 system. And also I want to emphasize the way community engaged and the community-based approach to address that. Next slide, please. Many of us know suicide was the second leading cause of death for young Americans, but many of us may or may not know suicide actually was the #1 cause of death for Asian American adolescents. Next slide, please. Next, please. Next slide, please. I think slides are frozen.
Yeah, I guess keep rolling and maybe we'll catch up, I hope. Thank you.
Okay, thank you very much. So according to census data, actually 1 in 9 Asian American adolescents have a major depressed episode in 2016, has been significantly increased over the years. So there are many factors impact this. For example, family conflict. You can click through that. Patient-child relationship, intercultural, intergeneration differences. Many are affecting all populations, but they are seen specifically for Asian Americans, including being immigrants, low English proficiencies, self-image identity, ethnic identity issues, or bullying, discrimination because you have different names, or academic pressures. You all know we have tiger mom, tiger daddy, and also religious identities, and the biological genetics, family history influences, and physical health issues. You may have heard even the Surgeon General of the United States and the President of National Academy have talking about these issues when they are young. Next slide, please. Next slide. So with all that, SAMHSA, the National Institute of Mental Health and Health Disparity, and Asian American Health Initiative in Montgomery County started a Healthy Mind Initiative, reaching out to different communities, including Indian temples, Philippine embassies, Korean church, Chinese language schools, to discuss the issue of mental health, increase awareness, and also provide methods, approach to address stigma. So that is very important, especially have people speak the same language, go into the community who understand the culture and can specifically target and address these issues. This is also very important for the dissemination and the implementation of 9/8 initiatives, having the inclusive excellence in there, have people have the same language and understand the cultural background to address the issues. In expanding the Healthy Mind Initiative, actually, we're working with National Institute of Mental Health and Kevin Foundation issued the first national essay contest to increase to encourage high school students 16 to 18 years old discuss speaking up about mental health. This is my story. Received over 230 essays across the country from 34 states and Puerto Rico. Eventually, 10 of them received awards and 2 received honorable mentions. With the support from SAMHSA, National Child Health, National Institute of Mental Health, and the NIMHD and NIHFDA, Federal Asian Pacific American Council, we are working on the second context to address the entire nation. Thank you very much for the update. It's very honored to join this discussion. Thank you.
Thank you. Brandon Johnson from SAMHSA, my colleague, roll ahead.
Thank you so much, Dr. Pearson. So today I really wanted to get an opportunity to speak specifically around Black youth and how 988 can be utilized to improve outcomes specifically within that population. Next slide, please. To set some groundwork, this has been a topic and one that has gotten increased focus over the past few years. Unfortunately, due to the emergence of some new data around suicide in Black youth. Particularly one data point that I would like to put out is that there has been almost a 2-fold increase in the suicide rate of Black youth between the ages of 5 and 12. This is something, this is happening gradually over about the last 13 to 15 years. And, when this data point got released, it was one that caused a lot of alarm and attention, to the point that the Congressional Black Caucus released a report called the Ring the Alarm Report, which was developed by an emergency task force focused specifically on Black youth suicide. In addition to that, Dr. Michael Lindsay, who you see in this slide, also released a study looking at YRBS data and finding a significant increase in suicide attempt, particularly those that require some type of medical assistance in African-American adolescents across the country, specifically between the ages of 13 and 17. And so as a result of this, the Department of Health and Human Services was asked to create a report specifically around this population. And so myself, Dr. Pearson, a number of us as well, worked to develop the HHS report to Congress on African-American youth suicide, where we really looked into some of this data, what was impacting and influencing these increases in suicide rates among African-American youth, and looking at some of our National Violent Death Reporting System data. One of the circumstances around the death of young African-American youth, which was different than others, was this issue around experiencing a traumatic event around in the previous or upcoming 2 weeks of the suicide death, along with family relationship issues. As we think about that and think about that data point and think about some of the things that we already know, 988 has a unique opportunity to meet some of the needs of our African-American young people in this country. Next slide. So with this, there are a number of things that I want to point out today in the time that I have. One, as Jennifer mentioned, is so important for our local crisis centers who will be answering these calls to be equipped with resources that match and meet the needs of our youth, resources that meet the needs for them specifically, those that incorporate community-based resources, faith-based resources, which I'll talk about again in a minute, but speaking to their real experience in this country. Our youth are aware of the things that we've talked about across this phone conversation. Some of the civil unrest, the murder of unarmed Black people in this country, experiencing stress and racial discrimination at school and other things. So having resources to meet that will be pivotal for our local crisis centers as they're answering what we expect to be increased calls from various populations. Also, it's important to remember the family. As we talk about young Black children between the ages of 5 and 12, we're talking about a family unit. Oftentimes it'll be the parents reaching out to 988, asking for resources, wanting to know what they can do for their youth. And as we know, there has been structural racism, systemic racism that has really made it more difficult for Black families to thrive. And so it'll be important to have resources dedicated to the social determinants of health, those other things that make it more difficult for a family to access various services. So making sure that that is there is increasingly important as well. And also, as we think about having additional resources for this intersectionality. So, not just being a monolith, but understanding, and we talked about this in the report, the needs specifically of LGBTQ youth and others, youth who are experiencing homelessness, those in the foster care system. It is important for us to meet the needs and 988 to have those resources for our individual crisis centers. And those crisis centers do an amazing job already of understanding where those resources are and pointing people to those needs as well. And it's also important, again, to understand and remove, when we talk about the workforce, having trainings and talking about cultural humility and removing those biases. We know that African-American young males are seen as more criminalized. Young Black youth are expelled and suspended from schools at a disproportionate rate. So all of those things, can feed into some of the uncomfortability and some of the challenges that population specifically has. So this is an opportunity for us to ground ourselves specifically in the needs of various populations, to use the data that we have, create resources that are timely, that are relevant, and that speak to the specific needs across these groups as best as we can, and ensuring that cultural humility is there to pick up and understand those aspects that we may have not accounted for. And so with that, I would like to turn it back over to Jane.
That's great. Thank you. And we're also tapping into another area of your expertise in terms of faith communities as being a resource. So I think we'll just let you keep rolling.
I'll pick the baton back up.
Yep.
Next slide, please. So, in this additional time that I have, I wanted to talk specifically around faith communities and engaging with faith communities as a part of 988. And so I'm putting on my role of being the co-lead of the Faith Communities Task Force of the National Action Alliance for Suicide Prevention, where I co-lead that with Dr. Melinda Moore from Eastern Kentucky University. Next slide, please. So as a part of this, as we think about faith communities in suicide prevention, we think about what are the roles of the faith community specifically as a part of this work. And as we look at the National Strategy for Suicide Prevention, there are a number of things specifically that faith communities can do to help individuals who may be at risk for suicide and suicidal ideation, in helping coordinate suicide prevention services and get people connected to services, creating referral lists, engaging with community partners, and making sure individuals have access to services, as well as being able to do some education, some psychoeducation as well, and engaging individuals who want to understand more about mental health and to understand how it impacts them and others and how they can be supports as well. And also providing care. Naturally, as myself and our team, as we engage with faith communities, and sharing with them, we understand that faith communities oftentimes are already doing this type of work in promoting hope and healing, and as well as making linkages to services and instilling in individuals a increased sense of purpose as well. And so it's so important that when faith communities are already doing this work, it's so important for us to engage with them, to assist them and have them be partners in this. And we envision at the National Action Alliance Faith Community Task Force of faith communities being integral partners in the rollout of 988. Next slide. As we begin to engage and roll out, we'll be reaching out to faith leaders across a number of faith communities engaging with them and helping them to understand what the potential of 988 is. There is a built-in natural trust between individuals in their faith communities. There is a sense of connection. And so as we have faith communities engaging in these conversations, it does a number of things. It normalizes the conversation and removes some of the stigma around accessing mental health services. So as we engage with faith communities, their connections and conversations specifically to encourage, their faith community to engage in 988 and those resources will be a major piece for this as well. We'll be working with faith communities to help them if they want to develop specific dissemination materials for the rollout of 988. Faith communities, as we engage with them and work with them, they want to be helpful. They want to know how to give everything that they can to support individuals in living the best lives that they possibly can. So engaging with them and helping them to have additional materials on top of the materials that we already provide as a part of our Faith Hope Life initiative, it is so critical for us to be partners with them, help them, create some materials and get the word out as well. We also create dialogues and have informational sessions and webinars with faith leaders across the country. And when the rollout of 988 is on and active, we will be doing the same thing there as well. Fielding questions, having individuals be able to ask us, what the implication is and what can they do to help. And so as we look at suicide prevention as a whole, faith leaders have a major role in this work. We at the Faith Communities Task Force are looking forward to continuing these conversations with faith communities, continuing to build upon resources. And again, this also is a piece of equity because we know disproportionately communities of color have an increased connection and get additional supports from faith communities. So as we're building this out, we're creating a better system as well for communities of colors, those in rural communities, giving them access to an additional place of information and resource gathering. And so with that, I will turn it back over to Jane.
Great, thank you. Our next speaker is Sam Brinton. Take it away, Sam.
Hello, everyone. Excuse me. Hello, everyone. My name is Sam Brinton. I use they and them as my pronouns, and I get to serve as the Vice President of Advocacy and Government Affairs at the Trevor Project. If you don't know what the Trevor Project is, we are the nation's LGBTQ suicide prevention and crisis intervention program. I apologize if my voice sounds a little bit raspy today. This is the first time back after about 48 hours of a really bad cough. So if you can't hear or understand things that I'm saying, please feel free to put it in the chat and I'll do my best to repeat as slow and clearly as possible. So what are we here to chat about today? We're here to talk about how 988 can actually serve everyone. We've learned about how communities of faith, communities of color, and communities from veterans and a variety of other high-risk populations can be served. And one area that I'm going to try to talk to you about today is going to be specifically LGBTQ youth. LGBTQ youth are at high risk of suicidal ideation. And we know this from a lot of different sources of data, but one being the National Survey on LGBTQ Youth Mental Health that the Trevor Project puts out each and every year. So a couple quick facts about that so we know why there's a problem, and then we'll get into the solution. First off, 42% of LGBTQ youth seriously considered attempting suicide in just the past year. This is more than half of trans and non-binary youth who have seriously considered suicide in the last year. But this isn't an equal playing field. As we've heard from Brandon and others, you have to recognize that there will be different populations having different risks. So for example, while 12% of white youth attempted suicide, 31% of Native and Indigenous youth, just like the ones that Pamela is trying so hard to work and serve, 31% of Native and Indigenous youth attempted suicide, again, just this past year. 21% of Black youth, as Brandon was talking about. 21% of multiracial youth. 18% of Latinx youth. It is a clear and present disparity between the different populations as each are trying to deal with compounding problems of being LGBTQ, a person of color, and variety of other experiences. Now, let's be very clear, politics has not made it much easier. 94% of LGBTQ youth said that recent politics has negatively impacted their mental health. But what we're here to talk about today is actually a big political win. And that's why I have this one slide with this awesome orange superhero because of a little bit of legislative text that has changed the world. What you heard from Richard McKeon, that the National Suicide Hotline Designation Act, and specifically the transition to 988, is a once-in-a-lifetime change. I cannot agree more. I truly tell my friends that at this point, it's really weird because the proudest thing I've done in my life may be happening really early in my life because the work to pass the National Suicide Hotline Designation Act and to implement 988 is truly one of the greatest things I will ever get to be a part of. And the reason that it is so monumental for the high-risk populations is because of a few little words at the end of the bill. Now, you can't read it all, but you can't read that text. It doesn't matter. It's printed in a big poster on my wall, but that doesn't matter to you. What you do need to know is that we have to recognize that 988 must serve everyone. And there's a requirement in the legislation that an implementation plan for what is called specialized services for a variety of high-risk populations, including LGBTQ youth, but also, of course, those who are rural or minorities or come from a variety of different perspectives, that all of them have to be served by 988. The reason this is so exciting, this piece of legislation, the National Suicide Hotline Designation Act, was passed unanimously with both houses of Congress and signed by a president, which is the very first time and the only time in history that an LGBTQ inclusive bill was passed unanimously. That is because we recognize that LGBTQ youth are at risk. And we also recognize that there are simple ways to solve this problem. One of those ways will be what is called integrated voice response. You will, just like you're able to reach the Veterans Crisis Line or for example, Spanish language services, you'll be able to hopefully, when 988 goes live, be able to directly connect to specialized services for LGBTQ youth. And that, my friends, is when 988 will truly be serving all. Thank you for your time, and I look forward to any conversations we have on this topic in the future.
Great. Thanks, Sam. Next up, we have Tracy Schneider.
Hi, everyone. My name is Tracy Schneider. I'm currently the Deaf Services Coordinator for the Arkansas Department of Aging, Adult, and Behavioral Health Services. I'm here to kind of talk about just access and how we can best ensure that everybody can use 988 when it rolls out. I will be voicing for myself because it's a little hard for me to condense this in the 5 minutes if I were to use ASL. So I also want to take a brief moment to describe my slides. My slide is a standard DHS template. It has a white background. It is blue at the top with my title in white. It has 2 text boxes. On the left, it just has a brief summary of my remark that I'm going to be talking about. And it just says that the 988 initiative will neither be truly inclusive nor fully accessible unless text message and direct video call acceptance capabilities are integrated into the rollout. And then it just has some info about me on the right side of the text box. So my current focus, again, is deaf services, deaf mental health. But my background is in policy development, vocational rehabilitation, accessibility, assistive technology, and things like that. You can reach me by email at tracie.e.schneider, that's SCHNEIDER, at dhs.arkansas, all spelled out, .gov. And then you can reach me by my video phone at 903-437-4254. So to really just get to the point, because I know that I tend to ramble, and I definitely don't want to ramble in English. There are different numbers right now for the deaf and hard of hearing, speech disorders, deaf, blind, anybody that needs to call for crisis services right now, especially whenever you're talking about suicide. There is a text number, there is a TTY number, and there is a speech-to-speech device number. And so when we talk about the rollout of 988, the goal is to make sure that everybody has one number to remember. And so whenever we roll out 988, if you have a VoIP or voice over IP capable device, it's going to be able to, like if you call from your cell phone or something like that, it'll route you to, getting the appropriate services. But if you're deaf and your primary language is ASL, you're still going to have to use something called a VRS provider, and that is video relay, where I open up my my ZVRS. I use ZVRS, so I open up my app and I let them know that I want to make a call. Sometimes I have to wait on an interpreter if everybody's busy, and then I make my call. So if I'm trying to call 988, I have to facilitate that through an interpreter. Because texting the 988 isn't available. Text to 988 would be absolutely wonderful, because not only would it be accessible to people who maybe don't want to talk on the phone. I don't like talking on the phone. I prefer to text. Then it would also be accessible for people who are deaf and hard of hearing as well. We also need direct video calling. I don't want to have to use an interpreter when hearing people don't have to use an interpreter. But again, I'm just one deaf person, and that's just my one perspective. But if we have the ability to support direct video calling, where you can directly call someone and you know that the other person on the other end of the line, when you call 988, knows ASL, then not only is it linguistically affirmative, it's also culturally appropriate. ASL is not English on the hands. It is its own language. There are cultural norms in deaf culture, just like there are in other cultures as well. And so having direct video calling would also be a benefit for deaf and hard of hearing communities who use ASL to be able to get accessible crisis services whenever they need it. And I really feel like that was the primary point that I wanted to cover. I wanted to make sure that we really had the chance to talk about the need for making sure that 988 is not only linguistically accessible, but also culturally affirmative too. So thanks for your time. And if you would like to contact me, you can email me. And I thank you again for inviting me to this.
Thank you so much, Tracy. And it's good to understand the avenue for texting being very helpful. It's really important. Next up is Sharon Hoover.
Thank you so much, Shane. Hi, everybody. Thanks for having me here today. I'm a professor of child and adolescent psychiatry at the University of Maryland School of Medicine, where I co-direct the National Center for School Mental Health, and I also direct the National Center for Safe Supportive Schools. And I will reference these centers along with a guidance document on best practices in child and adolescent crisis systems. And I just shared the links to those centers and that document in the chat box for your reference. My focus today in our brief time will just be on our young people and why schools must be a part of our systems of crisis response. So we know that many mental illnesses that lead to behavioral health crises could have been identified, maybe treated earlier in their trajectory, likely lessening the negative outcomes for young people and for families, including experiencing crises. And many of our youngest citizens, especially our young people of color, experience disciplinary responses in response to behavioral health crises, such as juvenile services or incarceration, for behaviors or experiences that likely could have been prevented or maybe best addressed with a system level response or a behavioral health response. And although I know that we must address the current feelings of our current crisis system for children, we should only do so while we're simultaneously building a universal behavioral health promotion and early identification and intervention system to minimize crises from happening in the first place. And I would just say that that can't be overstated and really should be a focus of every conversation regarding crisis response systems. And one of the most central tenets to creating accessible and equitable systems of crisis care and behavioral health care is to meet people where they are. And for many young people, if not most, this is in schools. And increasingly, we know that schools are installing what many are referring to as comprehensive school mental health systems, which reflect partnerships between education and behavioral health sectors to support a full continuum of mental health supports and services, all the way from mental health promotion to treatment. And we know that these comprehensive school mental health systems provide a full array of supports, often called a multi-tiered system of supports, or an MTSS in schools. So this may be universal mental health promotion for all students in schools, selective prevention for those most at risk to develop mental health conditions or challenges, and then indicated early intervention services such as clinical assessment or treatment for students who may screen positive for mental health concerns. Comprehensive school mental health systems, as I mentioned, really do rely on partnerships between school systems and community programs so that school employed professionals like our school psychologists, school social workers, school nurses, school counselors are meaningfully supported by community mental health professionals. And we know that when treatment is delivered in school settings, young people are far more likely to not only be identified early, but to initiate and complete care. And two areas that our center has been increasingly integrating into our work are cultural responsiveness and equity and trauma-informed and healing-centered approaches. So the three pillars, and you can see them here on our slide: comprehensive school mental health systems, cultural responsiveness and equity, and trauma-informed healing-centered policies and practices are the focus of our new National Center for Safe and Supportive Schools, which is part of the National Child Traumatic Stress Network funded by SAMHSA. And it's increasingly evident to educators and to the mental health field that for all students to feel safe and supported in schools and to support their behavioral health and well-being, we must not only put mental health supports and services in place, but also ensure that all of our approaches are culturally responsive, anti-racist, and equitable, and that they're delivered through a trauma-informed and healing-centered approach. And we know that an essential component of comprehensive school mental health systems is crisis prevention and response. So the installation of comprehensive multi-tiered systems of mental health support in schools has been demonstrated to actually reduce emotional and behavioral health crises. So for example, we just finished a 5-year implementation and study of crisis prevention and response that was funded out of the National Institute of Justice. And a couple of the features that we included were peer training for students from various social groups in each school who were trained in conflict management and bullying prevention. We had online virtual simulation technology to train teachers on how to support students experiencing psychological distress. There were clear referral assessment and coordination processes. We had a structured process for post-crisis prevention. And we found a whole wealth of positive outcomes, including 56% fewer suspensions in our intervention schools, 76% fewer office referrals, and more on-site crisis response as opposed to off-site referrals to emergency departments or law enforcement. So I'll close there given our time constraints, but I urge everyone to keep children, adolescents, and young adults in mind as we roll out our 988 system. Thanks, everyone.
Thank you, Sharon. Wow, that was a lot to go through and a lot of great resources. So I hope people can actually get back to the recording and hear all of the great suggestions that folks had. We do have some questions, and I guess it'll be open to all the speakers so far. So I'm going to start with some of the questions that popped up on the Q&A early on, which were about, is 988 actually free? Does it cost anything to call? And then a second one, and maybe Richard or Anita or somebody from SAMHSA would address these two questions. Is it accessible outside the US, or is Canada going to do something at the same time, or how will all that work? So I don't know if Richard or Nita are
Sure, I'm happy to do that. Just like the current 1-800-273 talk number, calls to 988 will be toll free. So there would not be any issue around that. There could be issues about, people's minutes on their cell phone, that kind of issue, but there would not be a cost. That cost will be absorbed by SAMHSA's Lifeline grant, just as it is currently. And then geographically, 988 will be accessible across all 50 United States, as well as to the U.S. territories, such as Guam, be accessible in Puerto Rico. It would not be accessible in other countries, such as in Canada. But we do have ongoing conversations with our Canadian colleagues because, you know, particularly near the Canadian border, if you're in Toronto, if you're in Buffalo, you know, the calls can go to one system or the other. The Public Health Agency of Canada and the Mental Health Commission of Canada have also asked for information from us around the whole process of the 3-digit number so that they can take a look at that themselves.
Great. And it also sounds like people were learning from the UK from that 3-digit number, and we're willing to share our lessons learned too going forward. That's great. There are also questions, stay on, Richard, about, so some states already have a 3-digit number. I guess Maryland has a 211. And how will that transition, or is it up to the states, or how will that work?
Yeah, so there are states, Connecticut, where our new assistant secretary is from, North Dakota, Maryland, that are using 211 as a statewide number. And then other states are using different numbers. The Georgia Crisis and Access Line has its own number. Rocky Mountain Crisis Partners, Colorado, has its own number. So that will really be a state determination. There will nothing in the changes to the technology will change what happens to a call when 211 is dialed in a particular locality. So those will be very important conversations moving forward, because obviously if all those calls switch over to 988, then that means the need for additional capacity for the local lifeline centers answering, those calls, if they're not the center answering those calls, already. So anyway, that's an important issue.
Great. A number of the presenters talked about, it's really important, of course, to have these crisis services, have them evidence-based, doing the best we can, quality improvement. But wouldn't it be great if we could get to the point where there were fewer crises in the first place? So Vic mentioned this. Sharon mentioned multi-tiers in schools. I'm wondering if some of you who didn't mention more earlier intervention want to make some suggestions. Anybody want to jump in that hasn't already spoken to kind of more upstream work?
Well, I'd be happy to. I don't want to dominate the discussion, but I'll mention a couple of things. I think in the suicide prevention field, I think there's an awareness that what you need to do to intervene with people who are in suicidal crisis be quite different than what we need to do to prevent somebody from being suicidal in the first place. You could actually think of it in terms of 3 levels. What are the prevention strategies that can help prevent people from being suicidal in the first place? Secondly, if somebody's having suicidal thoughts, what can we do to prevent that from being an acute suicidal crisis? Because not everybody who has a suicidal thought necessarily is in a state of acute crisis and needs to have police, EMT, etc. And then the third level is when it is indeed a suicidal crisis, when somebody might be at imminent risk, etc. Obviously, 988 should be available. Someone does not have to be thinking about suicide to call the existing National Suicide Prevention Lifeline. That will continue to be the case for 988. The law designates it as the National Suicide Prevention and Mental Health Crisis Hotline.
Great. And I think like Mayer's approach about if you were doing parent training, how would you make it more culturally, accessible at that point where you're trying to address things early on is really important. And a number of other folks described that too in terms of awareness of getting help earlier. Mary Ann, I'm going to put it back to you because I think you worked really hard in the community to shift the crisis piece, but what about that earlier upstream? And then I see Sam also had raised.
Thank you, Jane, for asking. Actually, it relates very well to this particular example because Errol had, and all this, again, I'm going to say is public information because obviously there was a trial and follow-up and all those kinds of things that have since been settled. But if you look at the history, this was an individual who, not dissimilar to many people that you might know, would take medication or get treatment and feel better and think he could do it on his own and wanted to do on his own, but he didn't trust. I mean, he just didn't trust, and I can't blame him because in community mental health, you don't show up, it's just a no-show and we move on. And unfortunately, fortunately, we now have a behavioral team, response team that is made up of psychology and nurses and some other folks in the county that actually go out and find people. And our community policing efforts are teaching folks how to respond differently, teaching the police how to respond differently. So we made some headway, some striking headway, but I think 988 will be such a benefit. I just can't, California passed it in April. I haven't seen the movement go, but we hope we hear more soon.
Great, thanks. Sam.
Sure.
Thanks so much. And I think when I think of preventative, right, I have to think what is putting this person in a situation where they think they need to call 988. And the thing we actually need to do is we need to create it so that it's okay to call 988 when you have a bad day, right? Like if we are doing our job as a nation, then 988 is ready no matter what level you're at, that we can answer that phone or that text message quickly and efficiently and let you know that we're spending time with you, that you're not alone. That is the major preventative activity in this work. So what does that look like? Building off of Sharon's great efforts, we need every single school to have a suicide prevention policy. You need teachers to know that 988 exists. I cannot wait for my children to come back from kindergarten and say that they just learned about 988 from their teacher, and I will just be beaming, being like, yeah, finally. Like that's a good moment. That's going to be a really big moment of prevention. But it's also going to be really important that we make sure that, like as Brandon said, that our pastors know about 988, right? That our mental health professionals, all of my therapists needs to know about 988 so that way they will start to recommend this service and it becomes a normalized process. That is all different forms. Parents, the national PTA needs to be boosting 988, which we've had many conversations with them, they will be, but like boosting 988 out to every parent so that way, guess what? Whether they're in the school or at home, a young person knows that someone's there for them. So I just want to think, when we think prevention, we need to be making sure we're thinking across the board, not just to the typical partners.
That's great, because one of my other questions was, what should people be doing right now? And you just went through a great list of letting everybody who should be knowledgeable about it know about it. And is there more information beyond that that you'd point them to? Or I think somebody had mentioned, contact your local crisis center first. I think it was Jennifer talking about get familiar with what they do, who they know. But are there other resources maybe in your state or county that people would suggest making connections with? I'm sorry, I see Barbara's hand up now. It might have been up for a long time. Okay, first, let's see if there's anybody have more suggestions.
I would be a bad advocate if I didn't take 5 seconds to say that we still need to pass state level legislation on 988 in most states around the country. So although a National Suicide Hotline Designation Act was passed, state level legislation is critical. And I know that this is we have to be very temperamental about who can advocate in that way, but I'm an advocate. So I can do that. And I can say, you need to be going and checking what your state is doing around 988 implementation. There are a variety of different pieces of legislation, from studies to implementations, that need to be getting your support.
That's great. Thank you. And now we're going to move to our closing session. Great job, everybody. I'm going to turn it over to Barbara Lamandry and David Covington. Thank you.
Thank you. Am I unmuted? Yes. I think we've had an absolutely spectacular panel, and I so appreciate how research-based, culturally relevant, and inclusive all of these comments have been. So in the Olympic tradition, my job is to bring the relay team home, and that's what I want to emphasize right now. For one, I think 988 is definitely a long overdue community intervention in suicide prevention, and it will make it easier to ask for help. Now, let me point out something. The United States was based on the Declaration of Independence, and so please understand, and this is an apology to my Asian and Latinx and Indigenous and African-based friends, white people don't ask for help easily. And I think 988 will help all of us ask for help easier. That being said, I don't think it's going to be the cure-all. We still have to reduce stigma, and I think 988 will help with that. We also need to be aware that suicide is a crisis of equal emergency as heart attack. That means that, you know, it took a few decades, but CPR is now a community intervention. I think you can be in a shopping mall and someone fall out and someone is going to step up and do CPR. Well, suicide prevention is mental health CPR. And I think we need to have everyone trained in the basics. What's good news, and our speakers have all emphasized based on the robust research in suicide intervention and suicide prevention, shows us that the skills for suicide prevention are simple, very simple. And that is, we ask the question, are you thinking of killing yourself? We listen to their response without any judgment. And then we connect them with others. That's based on good, solid research. And some people call this QPR, question, be present, and refer. So QPR and CPR, those are our basic skills for every person in the United States and our neighbors, Canada and Mexico. What we need to recognize is that suicide prevention is effective. Suicidal thinking and behaviors are a transient state of extreme impulsivity and lack of perspective. Having someone else step in and be a source of hope and perspective can be an immense improvement in the struggle for the person with suicidal thinking and behaviors. We need, and I think several of our speakers mentioned this, but I'll credit Pamela Andefjord. I love that statement. We need to take care to the person in their setting and in their culture. That means we need to be there present. Now, and most of us are healthcare, mental health care providers, professionals, but in cultural humility, let me emphasize, family, friends, and neighbors are the most essential first responders in suicidal crisis, not the mental health person. We get them after they're in the crisis, after they've made an attempt, but it's the neighbor, it's the family member that's first hearing it. They don't know what to do. They have an emotional connection to the person, and we can teach those skills. We've made sure that all of our healthcare professionals, in order to renew their license, have to have a suicide prevention training. We need to do that like CPR in our community. And lastly, I think the point is we need to consider systemic approach to suicide prevention. I think that COVID-911 or the COVID pandemic has taught us that our healthcare system and our mental health care system is broken, and we need to improve on that as well. My last slide is two resources for training. And one is for training for nurses, which is also applicable to any healthcare professional, and the other is for community. Thank you, and I thank the Academy for a wonderful presentation.
Oh, thank you, Barbara, and thanks so much to the leadership for the National Academy of Science, Engineering, and Medicine for hosting this important day. For those of you who saw last week, Jeff Bezos and the Blue Origin team on a reusable rocket in 10 minutes and 30 seconds, lifted off from the ground, went 60 miles into space, experienced weightlessness, and then returned safely to the ground. A remarkable feat that they now want to go further. They want to circumnavigate the globe. They want to travel to the moon, to Mars, and have space stations out that people could visit and even live on. They seem like fanciful goals, except that they have an approach that is from a motto: step by step, ferociously. They just keep moving forward. The kind of mental health, addiction, and suicidal crisis system that we're talking about can seem a little bit like those space travel type of fanciful dream that we've got. And yet we created exactly that in the emergency medical response system. 911 didn't exist in the mid-60s, but its emergence galvanized our efforts and created a promise, a set of expectations for the public around immediately available care to anyone, anywhere, anytime. And today we have this combination of an easy to remember 3-digit number that is readily accessible, that has resources that can be on the scene for the vast majority of Americans, and for those who need further help and support, that care can be available as well. That's not what we have in our mental health crisis space today. We talk about this system as being complex, fragmented, hard to negotiate. It's worse than that. It's much worse than that. The common experience for a person on their worst day is that they perceive what happens not as care or support, but as punishment. They're detained, they're delayed, they're denied care, they spend time in hospital emergency departments. Many, many thousands are transported by law enforcement every day. And in our experience, about 70% of them are handcuffed in the back of the vehicle. So we now have, with 988, with this, and we already had the emergence of focus on crisis care, the leadership of SAMHSA and NASEM and others, the priority of more effective care, care rooted in social justice, responding to the Department of Justice lawsuits as well, concerns about public safety, concerns about effectiveness. All of that was brewing before 2020. And now this combination of COVID's pressure on hospitals, discussions of race and equity, the role of law enforcement in this process, and the galvanizing promise of 988 to create something different for everyone in crisis, but in particular, the way that we have over-relied on law enforcement for people of color, the way we have under-attended to the crisis needs of LGBTQ. This is an amazing day and an opportunity to transform this care in ways. Richard McKeon's called it a once-in-a-lifetime opportunity to transform mental health care, and that's exactly what we have. So all of these presentations are going to be available on, if we can go to the next slide, we've got a link that shows where these resources are going to be archived. And next slide, just for all of you who's doing this, or who have been doing this important work and are pioneers in setting the architecture of care and concern and support in a really different sort of culture and a really different sort of country. Thank you for your continued leadership and for presenting, and for all of you who attended and took part We really appreciate your engagement. It's a collective impact as we move forward. We've been taking these steps and we'll continue to do so. And the folks that we serve are worth it, so we'll do it ferociously. Thank you.